The spleen, the largest of the lymphatic organs, purplish color, located intraperitoneally, left upper abdominal quadrant, surrounded by peritoneum with exception at the hilum, where the splenic branches of the splenic artery and vein enter and leave, posteriorly associated with the 9th through 11th rib, separated from them by diaphragm and costodiaphragmatic recess. Extension to the pleural cavity between the diaphragm and the lower part of the thoracic cage. Normally does not descend inferior to the costal rib region. It rests on the left collic flexure. We can find the spleen this way: anteriorly the stomach, posteriorly the left part of the diaphragm that separates it from the pleura, lung, and the rib 9 through 11. Inferiorly the left colic flexure, medially the left kidney. Varies in size, weight, shape, approximately 12 centimeters long and 7 centimeters wide, roughly size and shape of clenched fist. The diaphragmatic surface of the spleen, convexly curved to fit the concavity with the diaphragm. Anterior and superior borders of the spleen are sharp, notched, and posteriorly and inferiorly borders are rounded. Contains large quantity of blood expelled periodically into the blood circulation by action of the smooth muscle in its capsule and trabeculae. The artery, the splenic artery, large size, indicates the volume of the blood that passes through the spleen, capillaries, and sinuses. The thin capsule of the spleen, made of dense, irregular fibroelastic connective tissue, has occasional smooth muscle cells. The capsule thickens at the hilum of the spleen. Internally, the trabecula arising from the deep aspect of the capsule carry blood vessels to and from the parenchyma or splenic pulp, the substance of the spleen. The spleen contacts the posterior wall of the stomach and it is connected to its greater curvature by the gastrosplenic ligament and to the left kidney by the splenorenal ligament. These ligaments, containing splenic vessels, are attached to the hilum of the spleen on its medial aspect. Except at the hilum, these peritoneal reflections occur. The spleen is intimately covered with periosteum. The hilum of the spleen is often in contact with the tail of the pancreas, constituting the left boundary of the omental bursa. The splenic artery, large branch of the celiac trunk, follows a tortuous course posterior to the omental bursae, anterior to the left kidney, and along the superior border of the pancreas. Between the layers of the splenorenal ligament, the splenic artery divides into 5 or more branches that enters the hilum. The lack of anastomosis of arterial vessels in the spleen results in the formation of vascular segments. The splenic vein is formed by several tributaries that emerge from the hilum, joining by the IMV, running posteriorly to the body and tail of the pancreas throughout most of its course. The splenic vein unites with the SMV posterior to the neck of the pancreas to form the portal vein. The splenic lymphatic vessels leave the lymph nodes in the hilum and pass along the splenic vessels to the pancreatic or splenic lymph nodes. These nodes relate to the posterior surface and superior border of the pancreas. The nerves of the spleen derive from the celiac plexus, distributed mainly along branches of splenic artery and are vasomotor in function. The pancreas, an elongated accessory digestive gland, lies retroperitoneally and transversely across the posterior abdominal wall, posterior to the stomach between the duodenum on the right and the spleen on the left. The transverse mesocolon attached to its anterior margin, the pancreas produces an exocrine secretion, pancreatic juice from the acinar cells that enters the duodenum through the main and accessory pancreatic duct. The endocrine secretion, glucagon and insulin from the pancreatic islets, the Langerhans, that enters the blood. For descriptive purposes, the pancreas is divided into 4 parts: the head, the neck, the body, and the tail. The head of the pancreas, the expanded part of the gland, is embraced by the C-shaped curve of the duodenum to the right of the superior mesenteric vessel, the left firmly attached to the medial aspect of the descending and horizontal parts of the duodenum. The uncinate process, a projection from the inferior part of the head, extends medially to the left posterior to the SMA. The head of the pancreas rests posteriorly on the IVC, the right renal artery and vein, and left renal vein, on its way to opening into the descending part of the duodenum. The bile duct lies in a groove on the posterior surface of the head or is embedded into its substance. The neck of the pancreas is short and overlies the superior mesenteric vessel, which forms a groove in its posterior aspect. The anterior surface of the neck, covered with peritoneum, is adjacent to the pylorus of the stomach. The SMV joins the splenic vein posterior to the neck to form the portal vein. The body of the pancreas continues from the neck and lies to the left of the superior mesenteric vessel, passing over the aorta and L2 vertebrae, posterior to the omental bursae. The anterior surface of the body of the pancreas, covered with peritoneum, lies in the floor of the omental bursae and forms part of the stomach bed. The posterior surface of the body of the pancreas is of peritoneum, and it is in contact with the aorta, SMA, left suprarenal gland, left kidney, and renal vessels. Take a look in your atlas, the pancreas, duodenum, biliary, bile duct, and spleen. As well the lymphatic drainage and the innervation of the pancreas and spleen. The tail of the pancreas lies anterior to the left kidney, where it is closely related to the hilum of the spleen and the left colic flexure. The tail is laterally mobile and passes between the layers of the splenorenal ligament with the splenic vessels. The tip of the tail is usually blunt and turned superiorly. The main pancreatic duct begins in the tail of the pancreas and runs through the parenchyma of the gland to the head, where it turns inferiorly and is closely related to the bile duct. The main pancreatic duct and the bile duct entire to the form a short dilated hepatopancreatic ampulla, which opens into the descending part of the duodenum at the summit of the major duodenum papilla. The sphincter of the pancreatic duct around the terminal part of the pancreatic duct, the sphincter of the bile duct around the termination of the bile duct, and the hepatopancreatic sphincter of OD around the hepatopancreatic ampulla are smooth muscle sphincters, controlling the flow of bile and pancreatic juice into the duodenum. The accessory pancreatic duct drains the uncinate process, an inferior part of the head of the pancreas, and opens into the duodenum at the summit of the minor duodenal papilla. Usually, the accessory duct communicates with the main pancreatic duct. In some cases, the main pancreatic duct is smaller than the accessory pancreatic duct, and the two are not connected. In these people, the accessory duct carries most of the pancreatic juice. This variation of the pancreatic ducts are explainable from their fusion and lack of fusion during pancreatic development. The pancreatic artery is derived mainly from the branches of the markedly tortuous splenic vein, forming arcades with pancreatic branches of the gastroduodenal and superior mesenteric arteries. 10 branches of the splenic artery supply the body and tail of the pancreas. The anterior and posterior superior pancreatico-duodenal arteries branches the gastroduodenal artery, and the anterior and posterior inferior pancreatico-duodenal arteries branches of the SMA supply the head. The corresponding pancreatic vein are tributaries of the splenic and superior mesenteric parts of the portal vein. Anyways, most of them empty into the splenic vein. The pancreatic lymphatic vessels follow the blood vessels. Most vessels end in the pancreatico-splenic nodes that lie along the splenic artery, but some vessels end in the pyloric lymph nodes. Efferent vessels from these nodes drain to the celiac, hepatic, and superior mesenteric lymph nodes. The nerves of the pancreas are derived from the vagus and thoracic splanchnic nerves, passing through the diaphragm. The parasympathetic and sympathetic fibers reach the pancreas by passing along the arteries from the celiac plexus and superior mesenteric plexus. They are vasomotor, sympathetic, and parenchymal, sympathetic, and parasympathetic to pancreatic acinar cells and islets. And their distribution Take a look in your atlas, the lymphatic drainage and innervation of the pancreas and spleen. The liver is the largest gland in the body, weighs 1,500 grams, accounts for approximately 1/40th of adult body weight, lies in the right and left upper quadrant, mainly on the right side, inferior to the diaphragm, separates it from the pleural long pericardium and heart. In addition to its many metabolic activities, the liver stores glycogen and secretes bile. Bile passes from the liver in the right and left hepatic ducts that joins to form the common hepatic duct, which unites with the cystic duct to form the bile duct. In addition to storing bile, the gallbladder concentrates it to absorbing water and salts. When food arrives in the duodenum, the gallbladder sends concentrated bile through the cyst and bile ducts to the duodenum. Surfaces of the liver has a diaphragmatic surface anterior, superior, and some posterior. The visceral surface, posterior and inferior, which are separated anteriorly by its sharp inferior border. The diaphragmatic surface of the liver is smooth and dome-shaped, related to the concavity inferiorly surface of the diaphragm. The diaphragmatic surface is largely separated from the diaphragm by the phrenic recess, spaces between anterior part of the liver and diaphragm. The subphrenic recesses are separated into right and left recesses by the falciform ligament. The hepatorenal recess, hepatorenal pouch, or Morrison's pouch, is a deep recess of the peritoneal cavity on the right side extending superiorly between the liver anteriorly and the kidney and suprarenal glands posteriorly. The hepatorenal recess is a gravity-dependent part of the peritoneal cavity. When in the supine position, fluid drained from the omental bursa flows into this recess. The hepatorectal recess communicates anteriorly with the right subphrenic recess. Recall that normally the recesses of the peritoneal cavity are potential spaces only containing only enough peritoneal fluid to lubricate the adjacent peritoneal membrane. The diaphragmatic surface of the liver is covered with visceral peritoneum, except posteriorly in the bare areas of the liver. Where it lies in contact with the diaphragm, the bare area is demarcated by the reflection of peritoneum from the diaphragm to it as the anterior upper and posterior lower layers of the coronary ligament. This layer meet on the right to form the ligament triangular, the right triangular ligament, and diverge towards the left to enclose the triangular bare area. The anterior layer of the coronary ligament is continuous on the left with the right layer of the falciform ligament, and the posterior layer is continuous with the right layer of the lesser omentum. The left layer of the falciform ligament and the lesser omentum meet to form the left triangular ligament. The visceral surface of the liver is covered with peritoneum, except of the bed of the gallbladder and the porta hepatis, where vessels and ducts enter and leave the liver. The visceral surface is related to the right side of the anterior aspects of the stomach, the gastric and pyloric areas, superior first part of the duodenum, the duodenal area, the lesser omentum, the gallbladder, the right colic flexure and right transverse colon, the colic area, the right kidney and suprarenal gland, the renal and suprarenal areas. Take a look in your atlas. the surface and peritoneal ligaments of the liver. The functional parts of the liver. The liver has functionally independent right and left parts. The portal lobes are approximately equal in size. Each part has its own blood supply from the hepatic artery and portal vein, and its own venous and biliary drainage. On the visceral surface, the right part of the liver is demarcated from the left part of the liver by the gallbladder foci inferiorly and the foci for the IVC superiorly, an imaginary line over diaphragmatic surface of the liver that runs from the fundus of the gallbladder to the IVC separates the parts. The right and left parts of the liver have medial and lateral divisions. Uh, the left side of the liver are separated by the falciform ligament. In current terminology, the left liver includes the caudate lobe and most of the quadrate lobe. Take a look in your atlas, the anatomical lobes of the liver. The posterior view, the round ligament, the ligamentum venosum, the anatomical left lobe is separated from these lobes on the visceral surface by the fissure for the round ligament of the liver and the fissure for the ligamentum venosum, and on the diaphragmatic surface by the attachment of the falciform ligament. The round ligament of the liver is the fibrous remnant of the umbilical vein that carried well-oxygenated and nutrient-rich blood from the placenta to the fetus. The umbilical vein remains patent in infants for a while, and individuals with portal hypertension abnormally increased blood pressure in the portal venous system. There might be a large preumbilical vein that course along the round ligament. The ligamentum venosum is the fibrous remnant of the fetal duct venosus that shunts blood from the umbilical vein to the IVC, short-circuiting the liver. Take a look at your embryology book. The porta hepatis, hepatic portal fissure is a transverse fissure on the visceral surface of the liver between the caudate and quadrate lobes, where the portal vein and hepatic artery enters the liver and the hepatic ducts live. The porta hepatis gives passage to the portal vein, the hepatic artery, the hepatic nerve plexus, the hepatic ducts, the lymphatic vessels. Peritoneal relations of the liver. The lesser omentum enclosing the portal tract, the bile ducts, the hepatic artery, the portal vein passes from the liver to the lesser curvature of the stomach and the first 2 centimeters of the superior first part of the duodenum. The thick free edge of the lesser omentum, extending between the porta hepatis of the liver and the duodenum, the hepatoduodenal ligament, encloses the portal tract, a few lymph nodes, lymphatic vessels, and the hepatic plexus of nerves. The sheath-like remainder of the lesser omentum, the hepatogastric ligament, extends between the groove for the ligamentum venosum of the liver and the lesser curvature of the stomach. Vessels and nerves of the liver. Liver receives blood from two sources, the portal vein, the hepatic artery. 70% the first one, 30% the second one. The portal vein, a short, wide vein, is formed by the superior mesenteric and splenic vein posterior to the neck of the pancreas. Ascends anterior to the IVC and divides at the right end of the porta hepatis into right and left branches that ramify within the liver. The hepatic artery, a branch of the celiac trunk, might divide it into the common hepatic artery from the celiac trunk to the origin of the gastroduodenal artery. The hepatic artery proper from the origin of the gastroduodenal artery to its bifurcation into right and left branches. The hepatic artery is well oxygenated blood from the aorta, and the portal vein carries poorly oxygenated but nutrient-rich blood from the GI tract, except from the inferior part of the anal canal to the sinusoid of the liver, at or close to the porta hepatis. The hepatic artery and portal vein terminate by dividing into right and left branches, which supply the right and left parts of the liver respectively. Within each part of the primary branching of the portal vein and hepatic artery are consistent enough to form vascular segments. A horizontal plane through the right lobe and lateral division of the left lobe plus the caudate lobe divides the liver into 8 vascular segments. The left lobe is composed of segments 1 through 4 and the right lobe segments 5 through 8. Between the segments are the hepatic veins, which are intersegmental in their distribution and function, draining parts of adjacent segments. The hepatic veins formed by the union of the central vein of the liver opens into IVC just inferior to the diaphragm. The attachments of these veins to the IVC helps to hold the liver in position. Take a look in your atlas, the lesser omentum and portal triad. The liver is a major lymph-producing organ. Between 1/4 and 1/2 of the lymph received by the thoracic duct comes from the liver. The lymphatic vessels of the liver occurs as superficial lymphatic in the subperitoneal fibrous capsule of the liver, Gleason's capsule, which form its outer surface, and as deep lymphatics in the connective tissue that accompanies the ramifications of the portal triad and hepatic veins. Superficial lymphatic from the anterior aspects of the diaphragmatic and visceral surfaces, and the deep lymphatic vessels accompanying the portal triads converge towards the portal hepatis and drain through the hepatic lymph nodes scattered along the hepatic vessels and thus in the lesser omentum. Efferent lymphatic vessels from the hepatic nodes drain into celiac lymph nodes, which in turn drain into the chyle cisterna chyli, a dilated sac at the inferior end of thoracic duct. Superficial lymphatics from the posterior aspect of the diaphragmatic and visceral surfaces of the liver drain towards the area of the liver. Here they drain into phrenic lymph nodes or join deep lymphatics that have accompanied the hepatic veins converging on the IVC and pass with this large vein through the diaphragm to drain into the posterior mediastinal lymph nodes. Efferent vessels from these nodes join the right lymphatic and thoracic ducts. A few lymphatic vessels follow different routes. From the posterior surface of the left lobe towards the esophageal hiatus of the diaphragm to end in left gastric lymph nodes. From the anterior central diaphragmatic surface along the falciform ligament to parasternal lymph nodes, along the round ligament of the liver to the umbilicus and lymphatic of the anterior abdominal wall. The nerves of the liver derive from the hepatic nerve plexus. The biggest derivative of the celiac plexus. And the hepatic plexus goes along the branches of the hepatic artery and portal vein to the liver, consisting of sympathetic fibers from the celiac plexus and parasympathetic fibers from the anterior and posterior vagal trunks. Nerve fibers and vessels and bile ducts of portal tract and the liver are along together. Other than vasoconstriction, their function is unclear. Take a look at the lymphatic drainage and innervation of the liver in your atlas. The biliary ducts and gallbladder. The digestive function of the liver is to produce bile, a yellow-green secretion for passage to the duodenum. Bile is produced in the liver and stored in the gallbladder, which releases it when fat enters the duodenum. Bile emulsifies the fat and distributes it to the distal intestine for further digestion and absorption. The normal hepatic tissue, when sections traditionally described as demonstrating patterns of hexagonal-shaped liver lobules. Lobule has a central vein running through its center, from which sinusoids, large capillaries, and plaques of hepatocytes, liver cells, radiates towards an imaginary perimeter extrapolated from surrounding interlobular portal tracts, portal vein, hepatic artery, and biliary duct, although commonly said to be the anatomical units of the liver. Hepatic lobules are non-structural entities. The lobular pattern is a physiological consequence of pressure gradients and is altered by disease. The bile duct is not central. The hepatic lobule does not represent a functional unit like a kidney of other glands. However, the hepatic lobule is a firmly established concept and is useful for descriptive purposes. The hepatocytes secrete bile into the bile canaliculi formed between them. The canaliculi drain into the small interlobular biliary ducts and then into a large collecting bile ducts of the intrahepatic portal tract, which merge to form the right and left hepatic ducts. The right and left hepatic ducts drain the right and the left lobes to the liver, respectively. Shortly after leaving the portal hepatitis, the right and the left hepatic unites to form the common hepatic duct, which is shown on the right side by the cyst ducts to form the bile duct. Part of the extrahepatic portal tract of the less omentum, which conveys the bile to the duodenum. The bile duct, formerly common bile duct, forms in the free edge of the lesser omentum by the union of the cystic duct and the common hepatic duct. The length of the bile duct varies from 5 to 15 centimeters, depending on where the cystic duct joins the common hepatic duct. The bile duct descends posterior to the superior first part of the duodenum and lies in a groove on the posterior surface of the head of the pancreas. On the left side of the descending second part of the duodenum, the bile duct comes into contact with the main pancreatic duct. These ducts run obliquely through the wall of this part of the duodenum, where they unite to form the hepatopancreatic ampulla. The dilation within the major duodenal papilla. The distal end of the ampulla opens into the duodenum to the major duodenal papilla. The circular muscle around the distal end of the bile duct is thickened to form the sphincter of the bile duct. When this sphincter contracts, bile cannot enter the ampulla and the duodenum, and bile backs up and passes along the cyst to the gallbladder for concentration and storage. The artery supplying the bile duct, or the cystic artery supplying the proximal part of the duct, the right hepatic artery supplying the middle part of the duct. Take a look in your atlas, the flow of blood and bile in the liver. And the posterior superior pancreatic duodenal artery. And gastroduodenal artery, supplying the retroduodenal part of the duct. The vein from the proximal part of the bile duct and the hepatic ducts usually enters the liver directly. The posterior superior pancreatic duodenal vein drains the distal part of the bile duct and empties into the portal vein or one of its tributaries. The lymphatic vessels from the bile duct pass to the cystic lymph nodes near the neck of the gallbladder, the node of the omental foramen, and the hepatic lymph nodes. Efferent lymphatic vessels from the bile duct pass to the celiac lymph nodes. The gallbladder measures 7 to 10 centimeters long, lies on the gallbladder fossa on the visceral surface of the liver. This shallow fossa lies at the junction of the right and left lobes of the liver. Relationship of gallbladder to the duodenum is closely that the superior first part of the duodenum is usually stained with bile in the catheter. The pear-shaped gallbladder has a capacity of 50 millimeters of bile. Peritoneum surrounds the fundus of the gallbladder and binds its body and neck to the liver. The hepatic surface of the gallbladder attaches to the liver by connective tissue or fibrous capsule of the liver. The gallbladder has three parts: the fundus, the body, and the neck. The fundus is the wide end, projects from the inferior border of the liver, and is usually located at the tip of the right ninth costal cartilage in the MCL. And the body contacts the visceral surface of the liver, the transverse colon, and the superior part of the duodenum, and the neck, which is narrow, tapered, and directed towards the fourth hepatis. The mucosa of the neck spirals into a fold. The spiral bulb, which gives the cyst ducts opens to the that bile can easily divert into the gallbladder when the distal end of the bile duct is closed by the sphincters of the bile duct and or the hepatopancreatic sphincter or when bile can pass to the duodenum as the gallbladder contracts. The neck of the gallbladder makes an S-shaped bend and joins the cyst duct. The cyst duct uh, measures 4 centimeters long approximately, connecting the neck of the gallbladder to the common hepatic duct. The duct passes between the layer of the lesser omentum, usually parallel to the common hepatic duct, which it joins to form the bile duct. The cystic artery supplying the gallbladder and cystic duct commonly arises from the right hepatic artery in the angle between the common hepatic duct and the cyst duct. Uh, the first often varies in the origin.